Welcome to CFRI's Cystic Fibrosis Community Voices, a video podcast series created by and for the cystic fibrosis community.
Hello, and welcome to CFRI's CF Community Voices, coming to you from our home studio in Palo Alto, California. I'm Sue Landgraf, Executive Director of Cystic Fibrosis Research Incorporated, CFRI, and I'm very pleased to welcome our viewers and listeners. We have a very special program ahead, but before getting started, I want to thank our generous sponsors, Vertex Pharmaceuticals, Chiesa USA, Gilead Sciences, Genentech, and Proteostasis Therapeutics. I also would like to note that no information presented in this podcast is intended for a patient's diagnosis or treatment. We hope you enjoyed the podcast. Thank you, and let's get started.
Hi, my name is Meg Dvorak, and I am the social worker for the Adult Cystic Fibrosis Program at Stanford Healthcare.
And I'm Yelizaveta Sher. I'm a clinical assistant professor of psychiatry at Stanford, and I'm also the Adult Cystic Fibrosis Mental Health Coordinator. Today, Meg and I are going to be talking about mental health in patients with cystic fibrosis.
The title of our presentation is Mental Health Treatment, One Size Does Not Fit All. And we're going to take a deeper dive into how we screen, assess, and help diagnose and develop treatment plans for our patients in cystic fibrosis. So just a little bit of review before I get started. For years, social workers and mental health professionals have recognized the indescribable emotional toll that CF patients and their families face in dealing with this disease. And we have been assessing and screening and developing interventions for our patients based on our own varied backgrounds and expertise and varying manpower across different centers. And it wasn't until the groundbreaking TIDE study was published in 2014 that the entire CF community got behind a more monumental shift of incorporating mental health services into the CF model of care. So this groundbreaking study demonstrated the intense prevalence of anxiety and depression among CF patients and parent caregivers, as you see here on this slide, as well as the impact on medical outcomes, which includes lung function, healthcare utilization, health-related quality of life, and other measures. So once again, this is a lot of review. A lot of you will recognize this study. So based on the TIDE study, an international committee for mental health was formed, and the committee introduced new guidelines last year, which included mental health screening annually, prevention services, and education in all CF centers. And the committee also recommended the creation of a new role on the CF care team, the mental health coordinator, which is funded by a special 3-year grant through the CF Foundation. And 84 centers got funding for this special position in 2015. And since that time, 37 additional care centers now have a mental health coordinator. And the job of the mental health coordinator is to conduct mental health screenings in all CF patients ages 12 and over and parent caregivers, and to at least annually, and then to follow up on elevated scores. And so the mental health coordinator role looks different at every single center. Sometimes it's a psychologist or a social worker or a psychiatrist or even a psych-trained nurse. But the essential functions of the job are the same. So this tool will look very familiar to a lot of you. This is our anxiety tool, which has 7 quick questions for anxiety. And once again, this looks familiar. This is a PHQ-9, 9 quick questions to screen for depression. And these tools are well validated and studied and used widely in primary care centers. And these are the tools that are recommended by the Mental Health Committee. This algorithm is a model that we use for screening and interventions, and this groups respondents based on score into 4 categories, depending on severity, from minimal to mild to moderate to severe. and it also serves as a guide for our interventions. You can see on the far right, there is a question on the depression screen about suicidal ideation, question number 9, and most CF centers are equipped to address an emergent psychiatric evaluation either within the CF clinic or within their care institution. And this is a more simplified visual of the screening scores and how we look at them. However, it's important to note that mental health assessment is a very intricate and individualized process, and it goes far beyond screening. And there's many principles that we use to guide and inform our mental health assessments and how we develop our treatment plans. And so what we've noticed in our clinic is that our scores tend to be on the low side, and that for many individuals, the screening is just not effective in really identifying the true need of the patient. And so we go ahead and do a more thorough mental health assessment. And at this point, I'm going to turn it over to my colleague, Dr. Sher, to discuss that.
So as Meg said, screenings do not reflect the whole picture, right? And we've identified that in our own center. And there are many reasons why patients might screen low but still have significant mental health needs. Sometimes appointments are so busy already that patients simply do not want to bother with additional, screening tool and check off questions low, but still suffer with depression and anxiety that they not feel comfortable sharing with others. Sometimes, the questions do not really talk to the patients, right? So they not ask the right questions. And I think that's true for a lot of our patients. And sometimes patients do not feel comfortable disclosing. They're not sure how they can be helped within this setting. There are other informational sources that we clinicians can use. Family and friends and other caregivers can share with us their concerns. Of course, we respect HIPAA laws, but if concerned family members will come up to us, we will hear what they have to say. Other clinicians, pulmonologists, nurse practitioners, dietitians might notice something and ask mental health clinicians to further evaluate. And also just interacting with the patient sometimes tells, of course, a bigger story than what the score truly reflects. Finally, the clinical interview. As Meg said, the individualized interview really what will tell us what are the patient's individual needs and how we can best help them. Once we do know that somebody does suffer from increased depression or anxiety, then we really need to think about the differential. And the differential for depression and anxiety can be pretty broad. It's important to understand exactly what kind of depression somebody has, because that can better educate us what are the options, what are the interventions for those patients. For example, major depressive disorder is a clinical depression, and it's not just feeling sad once in a while, which is absolutely normal for all of us, but it's really that persistent sadness, not enjoying things for more than 2 weeks, and which is accompanied by many other symptoms in addition. And it impairs patients' functioning. So if somebody does have major depressive disorder, this is where we do think about mind-body interactions, mindfulness, diet and exercise, the psychotherapy, but medications definitely would be more seriously considered. Versus somebody has an adjustment disorder. They have some symptoms of sadness, some symptoms of depression that do not meet criteria for a major depressive episode, but it still potentially can be impairing to their functioning. This is really where psychotherapy would be more appropriate, and maybe we will hold off on the medications. Really supporting the patient around their stressor is the right answer. If it's part of the bipolar disorder, patients will have depression, but they will also have manic or hypomanic episodes. And this type of depression, medication-wise, will be treated very differently. Unipolar depression will be treated with antidepressants, but with bipolar depressions, this is really where we rely on mood stabilizers. And it's very important to have then professional assessment at that point and treat with medications first, and then with psychotherapy as well. Anxiety can also have a broad differential behind it. So it's important to understand whether the patient has anxiety as a primary anxiety disorder, or maybe it's a side effect of their medications. So it's really important for us to disentangle. And there are different primary anxiety disorders. Understanding that can help us come up with a correct, therapy approach. In a generalist anxiety disorder, patients worry about everything that we worry about in daily life, the health, of course, relationships, school, work, finances, but they worry to the degree of being overwhelmed and impaired by that. With obsessive compulsive disorder, there is more a theme of worry. There's an intrusive thought that just keeps attacking the patient in daily life, and it can be very, very definitely intrusive and impairing. And the particular cognitive behavioral therapy that would be recommended to those patients is the exposure and response prevention therapy. With panic disorder, patients have attacks of panic. They feel that they are doomed and they're dying right now at the moment. It's different from pervasive worry. When you worry about the future events, right? How, my relationship is going to fail in the future. I'm going to get sicker in the future. My finances are going to suffer in the future. Versus when you have a panic attack, you think that you're dying right now. And again, this is important to recognize this particular anxiety disorder and treat it appropriately. With PTSD, post-traumatic stress disorder, we usually think of people who go through war, through violent crimes, right, or suffer from natural disasters. But having a chronic illness can be pretty traumatizing, especially if somebody gets hospitalized over and over, somebody's in ICU, somebody undergoes transplantation. So now it is recognized that within the CF community, within the transplant community, there's actually a high prevalence of post-traumatic stress disorder. So it's important to recognize that as well. And now I'm gonna give stage to Meg.
So bridging the mental health gap, that's our goal. And it's become a little bit easier now that we have screening rolled out in all the programs and the presence of the mental health coordinator. People are starting to recognize that mental health is a real medical problem and should be treated with the same degree of importance as the physical symptoms. And we're starting to see more mental health professionals on CF center care teams, which include people with different educational backgrounds and levels of training. As I mentioned before, psych-trained nurses, MSWs, all the way up to psychiatrists to carry out these initiatives. And to help these professionals, the CFF has created this amazing mental health toolkit, which is available to all providers on Dropbox. And it's got a plethora of mental health resources, including a PowerPoint that can be given to therapists in the community who don't have any knowledge of CF to help them get up to speed on the disease, so that when patients go to see those people, they don't have to spend 3 sessions explaining what they go through every day. And the mental health services are definitely evolving as the patient demographic changes, as people age with this disease. And there just needs to be a more broad array of services, including just, in addition to just the traditional approaches. And CFRI and the CF Foundation are definitely recognize that, and there's more programs than there used to be. So mental health has long been considered the red-headed stepchild of the healthcare system, where insurances fail to cover necessary services and they just create obstacles and red tape for patients and for therapists. Overall, patients bear about 16% of the cost of mental health services, and that's a bigger proportion of any illness studied. And this is according to research that's been done by the Agency for Healthcare Quality. So in addition to the obvious insurance and financial barriers, we recognize that people are just burdened by this disease alone, the physical symptoms, the demanding daily care regimen, and also patients are burdened by their own mental health problems, and this is especially true for depression. And as I discussed briefly earlier, a lot of people don't want to waste time going to community therapists who don't really know what CF is, and they ask how you caught it, and they just find that a waste of time. And then lastly, there's still a negative stigma associated with mental health, and for some people, they feel shame in seeking treatment. So whatever your barrier is, we understand, and we want to close that gap as much as possible. And so here at Stanford, we have a psychiatrist as our mental health coordinator, and she is a faculty psychiatrist with special training in psychosomatic medicine, and she carries a large caseload of CF and lung transplant patients in her own practice, and so she has quite a bit of experience there. And as of last year, a year ago, right at this time, she's been embedded in all of our CF clinics. And in addition to helping us with the screenings, she provides psych interventions in real time as part of the CF clinic experience. And this includes psychological evaluations, suicide assessments, medication management, and at times, although unlikely, she can help facilitate a direct admission for a psych hospitalization or a partial hospital program in the community. And just having her around and present in all the clinics has really destigmatized the image of the psychiatrist. And for those patients who have never or would never consider seeking psychiatric treatment are getting linked to services.
So there are a variety of treatments available to all patients and to our patients, and based on availability, patients' preferences, and clinical needs, we can come up with with a menu for this particular patient. And in general, the options for mental health problems, for depression, anxiety, and so on, include diet. Proper diet is a very important part of mental well-being. Exercise, and we'll talk a little bit about that more, but we know that exercise has wonderful effects on your overall physical pulmonary health as well as your mental health. So really exercise can be part of all treatments. Meditation, it also can be added to all treatments. Peer support groups are very important. Psychotherapy and medications. We'll go a little bit through different psychotherapies. There are a variety of psychotherapy flavors. What kind of psychotherapy is the best for you? I think it really depends, first of all, on your bond with the therapist. The most important part of the effectiveness of therapy is the rapport between patient and therapist. So finding the right fit is important. CFF has recommended cognitive behavioral therapy as the first type of therapy for the interventions for the patients. And CBT definitely has been validated, it has been studied, it has been shown to be effective. But there are also many other psychotherapies that can be helpful for many patients. Psychodynamic psychotherapy, so I think a flavor of that is psychoanalytic psychotherapy, signified by the couch on our picture, but it's really about understanding of how one's past shapes today. And that's important, even if somebody does not practice psychodynamic psychotherapy, but those concepts are very important for the bond between the patient and the therapist, and also understanding who the patient is as the person. Motivational interviewing. We use that often when, potentially there's a conflict between what patient is doing and the patient's goals. So motivational interviewing can be helpful for the patient to see that difference, right? That something is not right. And for us to listen the talk of change from the patient, and for the patient to decide to change and come up with a plan. Cognitive behavioral therapy, as we discussed, is the one that is recommended by CFF. And it's really depends on this concept of relationship between thoughts, emotions, and behaviors. We feel certain things because there's thoughts, right, in our mind. And then in response to those thoughts and feelings, we do certain things. Sometimes that's helpful, sometimes that's not. CBT really helps us to recognize that link and work, for example, on some thoughts that are not so productive, which we call cognitive distortions, change them, and thus change our behaviors. Interpersonal therapy really looks at your relationships with other people in your life, your roles, and can also help with those changes in roles, or maybe resolution of grief that you might have. Existential psychotherapy talks about meaning of life and dealing with death and grief. And that actually also can be very important, especially as patients maybe approach later stages of their life and are grieving their life, their health, what they're going through. And it can be very powerful addition to the psychotherapy. Mindfulness, really it's an ingredient that can be present in all different psychotherapies. Being in the moment, right? Not thinking about the past, not worrying about the future, but really just being in this moment can be very powerful. And finally, supportive psychotherapy, when we listen to our patients, when we listen to their problems right now and try together come up with potential solutions. In terms of the medications, there are multiple medications. Really, patients will choose together with with their clinicians and psychiatrists, what is the right cocktail for you. Some of the older medications, MAOIs and TCAs, likely will not be prescribed in the setting. This probably would be fifth or sixth choice if needed. But sometimes, of course, patients are treated with those medications as well. SSRIs, selective serotonin reuptake inhibitors, antidepressants that classically we think of the ones that increase your serotonin in the brain, and really they are downstream effects that truly help you with your depression and anxiety. And these are the primary medications that are recommended by the CF Foundation. Medications such as citalopram, sertraline, and fluoxetine. But again, these are initial recommendations. It's really the effectiveness of the therapy depends, of course, on patients' individual circumstances and response. SNRIs include medications like duloxetine and venlafaxine, and potentially can be helpful in patients who also have chronic pain. Atypical antidepressants, mirtazapine, can be very helpful for both depression and anxiety, can also help with appetite, with sleep, and with nausea. So we do often find that useful. Bupropion is another antidepressant you might have heard of. And this antidepressant is a bit more stimulating. So if somebody has problems with energy, with enjoying things, that might be helpful. And other augmenters such as lithium, thyroid, and aripiprazole, just to name a few. This is for some really, refractory depression. There are other medications that are not listed here, medications such as mood stabilizers that we would use for treatment of bipolar depression. And these medications would include both antipsychotics and anticonvulsants, but really we use them for their mood stabilizing effects. There are additional interventions that we've been introducing in our Stanford CF clinic that we are very proud of, and we hope that our patients enjoy. So one of the additions is our bi-monthly wellness newsletter that now we have been doing for a year. And this is a letter that mental health clinicians, so our social workers and myself, Meg, Stasia, and myself, we write this, and we also invite other members of the team. We write this every 2 months. And this is really to promote, to give kind of a taste of mental health, mental well-being to all of our patients, right? Because really everybody can benefit from mental health well-being. And topics include education about depression, or mindfulness, exercise, diet. For example, in August, September 2016, we talked about depression, and also we talked about a little bit cognitive behavioral therapy, and we introduced mood log ideas to the patients. Because in reality, these tools can be helpful for anybody, whether or not you suffer from depression. So we produce new newsletter every 2 weeks, and they're administered and given out to the patients at every clinic visit. And something that we are proud of and very hopeful about its effects is the new program that we are rolling out as of last week, and it's called CBT Coaching within CF Clinic. So we, of course, we all appreciate cognitive behavioral therapy, and we wish all of our patients had access to that. But as Meg mentioned, for a variety of reasons, patients not able to see CBT therapist every week. So we came up with a portable option, sort of the best that we can do in the CF clinic within our limitations. So this coaching model is based really on patients doing most of the work. All therapies are done, when the therapist and patients, they work together as a unit, right? They share responsibilities. This one, patient bears most of the responsibility, and the clinician within the CF clinic acts as a coach. We use the treatment workbooks, and there's an example of one of our workbooks for anxiety is on our slide. And there are different flavors of these programs that we have. We have one tailored for anxiety, one tailored for depression, and one tailored more for living with chronic illness and adherence. The program consists of approximately 6 to 7 sessions within the CF clinic. You don't have to come to clinic just to get the session. It's really embedded into your regular appointment. The sessions are conducted by a social worker or the psychiatrist in the clinic. During the clinic, we go over the homework, we go over the major concepts, and we give you homework for the next session. And this is where the work begins, where the patients go home with the workbook, they read, they do the homework, and then they come back. We're just starting it out. We're very excited about that. But of course, with time, we'll see how our patients like it and what the response and the results will be.
All right. So exercise, one of the more non-traditional approaches to treating mental health. This is recommended to all CF patients, regardless of physical functioning or lung status. And studies in CF have shown that exercise can help clear out mucus, and it slows the progression of lung disease. And additionally, other studies in other disease areas and in general have shown that regular exercise has many, many mental health benefits, including improved cognition, improvement in mood, immune functioning, focus, and memory. And for those with more advanced disease, pulmonary rehab can be life-changing, and I've seen some patients who have gone through it have been able to put off lung transplant a little bit further than they had expected to. And so if you want more information about exercise and the benefits of it in CF, there was a podcast a few months ago by Taylor Lewis. I recommend that everybody watch that. And you can also visit his website at cffitness.org. And from what I've heard, he can create an individualized fitness plan for each patient. And obviously there's other non-traditional options such as meditation, mindfulness, yoga, Tai Chi, Chinese medicine, all kinds of Eastern techniques. And if you're watching this podcast, you're probably already familiar with CFRI's 9-week mindfulness-based stress reduction class, which is offered around 2 to 3 times a year by a very experienced physician who also is an adult living with CF. It's for a very nominal cost, and it's offered in different time zones depending on the time of the year. And additionally, it's offered to CF patients and their caregivers. So for more information about this, you can just call CFRI or visit their website. And for those people who have found the perfect therapist in the community but can't afford the cost, CFRI has an individual counseling financial support program which can offer up to $120 per session for 5 sessions. Also inquire again with CFRI either by phone or website. And sometimes it can be very helpful to just connect with a peer who has the same disease. For individuals who may not have a mental health disorder but may be going through a rough transition, such as leaving for college or getting a G-tube, going on oxygen, or approaching lung transplant. This peer mentoring program through the CF Foundation is in its final stages of the pilot, and it's supposed to be rolled out nationally at the end of this year. And through this peer mentoring program, individuals with CF get matched with a peer based on a topic that they wish to know more about or something that they may be struggling with, as I just mentioned. Totally free of charge, and the matching process, they've really sussed out all the things that work and don't work through this pilot program. So I expect great things from this as the years to come. And that concludes our presentation. So just in conclusion, I just want to say that no person should ever go without mental health treatment in whatever form is deemed appropriate. And for those who may be struggling with something, please reach out to your social worker, your mental health coordinator, or any member of your care team who can link you or your loved one with the appropriate mental health treatment. And we're hoping that more care centers across the country can start moving beyond just the screening and start providing the interventions in the clinic.